finger pathologies. We've already talked about elbow, we've talked about forearm, talked about wrist and hand, and so we're just finishing off with finger pathologies. The first finger pathology that we're going to talk about is mallet finger. And mallet finger is most commonly seen in baseball and basketball sports, or sports where you have balls coming at the hand at high velocity. So I kind of want to draw your attention to this image in the bottom right hand corner of your screen to talk about the etiology or the mechanism of injury. Most often the etiology or the mechanism of injury is a direct blow to that distal phalangeal bone. So what we see is a ball coming at high velocity, and it contacts the tip or the distal phalange of that finger, and it forces the finger, at least the distal interphalangeal joint, into flexion. And that extreme flexion coupled with that high amount of force causes an avulsion of the extensor tendon. So let's go ahead and orient ourselves. The extensor tendons are on the skin or dorsal surface of the hand, okay? And then the flexor tendons are on the palmar surface of the hand. And so when we're thinking about an extensor injury, most often extensor injuries occur when there's a hyperflexion moment, either at the distal phalange or the middle phalanx or the proximal phalanx. It really truly just depends. In this case, for mallet finger, sudden force to that distal phalange, you get hyperflexion at the distal interphalangeal joint, and so as a result what you have is a rupturing of that extensor tendon. And that's really a bad thing, because if the extensor tendon, which attaches just distal to that distal interphalangeal joint, avulses, then there's no control over finger extensor. In other words, the body really loses its ability of that finger to extend itself or to bring that finger back into a neutral position. So your signs and symptoms are going to be tenderness to palpation and pain at both the distal interphalangeal joint and also the distal phalanx. And we're going to send that patient for x-rays because, number one, they're going to be swollen. They're going to be tender to palpation. So we really want to rule out an avulsion fracture or a fracture of the distal phalanx. And then once we do that, then we can kind of confirm that mallet finger exists. So mallet finger is a rupturing of the extensor tendon that supplies the distal phalanx. What we see in patients is that they're going to be unable to extend that distal finger because that tendon is no longer intact. And for sure, they're going to have point tenderness, maybe some ecchymosis in the distal interphalangeal joint as well as on the distal phalanx itself. And so what's the management? Well, the first management is really RICE. And as I've mentioned before with kind of the hand, but in particular the fingers are just so small in terms of their intricacy. And so when we have an injury to a finger, the swelling can't go anywhere, right? Because it's so small. It can't extend anywhere, so it tends to stay in the joint. So one of the treatments that I tend to do for my patients is also massage. And so I will massage my patients starting at the distal phalanx and then working my way up to the proximal phalanx. Last but not least, what we'll have to do is splint, and I'm going to show you a different slide of a specific splint that is used for patients with mallet pathologies. One thing that I do want to draw your attention to on the screen is the deformity that exists when you have a mallet finger. You can see here that the patient's distal phalanx is actually in a flexed position, and it stays in this position if the injury is mismanaged. In other words, if you don't treat it, if you do not splint it in extension, then you basically create a lifelong deformity that looks something like this. So the finger will stay in about 2 to 3 degrees of flexion at that distal phalanx. So it becomes important, very important for you to splint. And we look on this slide, what we can see is a concomitant injury that occurs with a mallet finger. A lot of times you have the avulsion of the extensor tendon off of that distal phalanx, and then with that avulsion sometimes, or with that avulsion of the tendon, what you'll also get is an avulsion of the distal phalanx or a piece of that bone. So we have to splint it in extension so that bone can tack down. And the other reason we have to splint it in extension is so that we can gain extension range of motion and also allow that tendon to heal. So as I've been mentioning, there's a specific splint that we can use, and that's the SAM stack splint. The stack splint really has this bottom that is rigid. All of it's really rigid. And this piece right here extends just distal to that distal interphalangeal joint. And that's intentional, right? We don't want the distal interphalangeal joint to flex, so we have to make sure that this bar, when we're fitting this splint, sits distal to that joint so no flexion can occur. I will tell you that when you apply this splint specifically if that patient's finger is stuck in flexion, this will be the most painful part for the patient. And sometimes, honestly, they get pretty upset. So you have about 5 to 10 seconds to get that splint on, tape it, and make sure they're in extended position. Some people have asked, can we participate? In baseball, if it's not on the throwing or dominant hand, then the answer would be yes, right? Because you have to be able to get into a flex position to throw a ball. So if it's on the dominant side, probably not. If it's on the non-dominant side, then absolutely sure, as long as your hand can fit in the glove. For basketball athletes, it's really a matter of if it's on the shooting hand and which fingers it's on. But we've had basketball players play with mallet finger before. The next pathology is a boutonniere deformity. A boutonniere deformity is different than a mallet finger for several different reasons. Number one, what we have is a rupturing of the extensor tendon as it passes over that middle phalanx. So right here we can see middle phalanx, right? We have the interphalangeal joint here, and then we have a rupturing of the extensor tendon. So it's no longer occurring to that distal extensor tendon, it's occurring to the middle substance of that extensor tendon. So that's number one. So one thing we see is a rupturing of the middle phalanx extensor tendon. And so what we see here are a couple of things. Number one, the distal interphalangeal joint will go into extension, and then the PIP, or proximal interphalangeal joint, will actually go into flexion. So you have forced extension at the distal interphalangeal joint and flexion at the PIP joint. So what are the signs and symptoms? Number one, they'll have this deformity. Can you kind of see it? I call it the L deformity. So you'll have extension at the distal interphalangeal joint, and you'll have kind of a flexion at the PIP joint. So you'll see the deformity. It'll be clear. It'll be obvious. They will not be able to kind of bring that middle phalanx into extension. And so that becomes really, honestly, a really big problem for this particular patient. So the focus is going to be on getting that proximal interphalangeal joint flexed. And so we'll create a splint, and we'll show you what that splint kind of looks like in just a second. The other thing that we tend to see is that patient will present with swelling, most specifically at the PIP joint. So not at the DIP joint, which is affected as well, but at the PIP joint, you'll see a massive amount of swelling. It'll almost look like another knuckle, essentially. And then there'll be tender to palpation. So treatment is similar to that with a mallet finger. You're going to ice it, you're going to splint it, you're going to definitely massage it. And then, again, the splint is going to be focused at the PIP and not necessarily the DIP. So let's take a look at a true boutonniere deformity. This is a boutonniere deformity at its finest, right? Remember, I said you'll have that knuckle-like appearance. That's because the tendon has been ruptured and there's lots of swelling within the joint. So again, we'll have to massage from the middle phalanx all the way up to that proximal phalanx. And then secondarily, what we tend to see is extension of the DIP as well, secondarily to that. But the extensor tendon distally is not disrupted. Just want to be very, very clear on that. So how do we splint that? We use a long stack splint or just a traditional splint. And we have to make sure that we're splinting the bone above and below that joint. So the proximal phalanx and the middle phalanx have to be included in that splint. At minimum, if you really want my humble opinion, I would even splint the distal interphalangeal joint and the distal phalanx as well. The next pathology is jersey finger, and for sure it gets its name from the sport that it occurs most in, which is basketball. A lot of times when athletes are cutting or when they're setting a screen, you'll see as the athlete moves by them that they try to go to grab them, and as a result, their finger gets stuck in the jersey. And when the finger gets stuck in the jersey, it is actually hyperextended, and what you have is a flexor digitorum profundus tendon injury. The flexor digitorum profundus, what we know about it is it extends to the distal phalanx on the palmar side. So now we're talking flexors, not extenders. And so it would be the equivalent to mallet finger of the extensors. In this case, what we have is a rupture of the flexor digitorum profundus off of the distal phalanx on the palmar side of the hand. I want to be very clear about that. It happens because as we go to grab the jersey, that athlete moves and that finger is forced into hyperextension, the opposite mechanism of injury for mallet finger. And so what you have is rupturing of that flexor tendon. Of course, just like with the mallet finger, you could absolutely have an avulsion of the flexor profundus, flexor digitorum profundus, as along with an avulsion of the distal phalanx bone as well. So what do we know about this pathology? Like what does it present like? Well, the DIP cannot be flexed because that flexor tendon that supplies and assists and moves the finger into flexion is now avulsed. So that patient will not be able to get into finger flexion, and the opposite of mallet finger, that finger now stays in extension. So you get a finger that looks hyperextended in essence. They're going to be tenderness to palpation over the distal phalanx and maybe even the distal interphalangeal joint as well. And so when we really think about jersey finger and mallet finger, we kind of have to rule out both of these pathologies. I think the differential is the position of the distal interphalangeal joint and the phalanx, right? Because in a mallet finger, you're going to have a flexed distal phalanx, and then in a jersey finger, you're going to have the opposite. You're going to have an extended distal phalanx. So how do we treat them? This one, interestingly enough, must be surgically repaired, and we'll talk about why in just a second. And the rehab for it is about 12 weeks after they're done with the surgery. And the biggest concern after the surgery really is the amount of buildup in the finger itself. So let's take a look at sprains, dislocations, and fractures of phalanges. You know what? Our phalanges in general are prone to strains because of the direct blows and the amount of twisting that might occur to them. In terms of sprains and dislocations and fractures, the mechanism of injury is the same. It's usually a direct blow, direct trauma to either the tip or the proximal interphalangeal joint, and it causes disruption of the joint or the bone itself. So with sprains, we tend to see those occurring to the either medial and or lateral side of the finger, right? And just like within the knee and within the elbow, we also have a UCL or an RCL or collateral ligaments that hold each of the joints together in the finger, right? So there would be a collateral ligament here to hold that joint in place. And so anytime you have a direct force that either causes a valgus or a varus moment, then you'll have a sprain of a joint. And if the joint doesn't sprain, then that force gets transmitted to the bone, at which point in time then we either have a fracture or what we see here is a complete dislocation of a interphalangeal joint. And so what are the signs and the symptoms? For a sprain, the signs and symptoms would be pain and swelling, as would honestly a fracture. The differential honestly would be an x-ray, right? It's the only way to really truly differentiate between a sprain and a fracture. I would say the other differential, quite honestly, would be laxity, right? With a fracture, you probably won't have laxity if the ligaments are intact. However, with the sprain, if the ligaments are actually traumatized, if there's a grade 2 or a grade 3, then you're going to have laxity about that particular joint of the finger. So that's just one differential for you. But the mechanism of injury for a sprain, dislocation, and a fracture relatively, honestly, are the same. The next pathology is gamekeeper's thumb. I know I have a few soccer athletes in the room, so this would be of interest to you if you were probably a goalkeeper. The thumb is an interesting joint, I think. Obviously, I keep saying it in class, but it's really what separates us from other mammals. The joint has a UCL, and so we could say, okay, well, here are the ligaments that kind of hold the metacarpal bone to the actual phalanx itself. And so when we have a ligament holding two bones together, then we have a joint, right? And that joint, we would kind of call it a knuckle, is the metacarpal phalangeal joint of the thumb, aka the knuckle. The mechanism of injury for a UCL injury or gamekeeper thumb injury is what we call a hypervalgus or hyperabduction of the thumb. So we can imagine that this part of the thumb moves away from the body. So we see that a lot in goalkeepers because as they go to catch the soccer ball, the thumb tends to get jolted a lot from the velocity of the ball coming at them as they go to catch it. And the other thing is goalkeepers usually tend to have wide finger and hand stance so that they can actually capture all of the ball and it doesn't slide through. So the etiology of gamekeeper's thumb is stretching of the UCL because the thumb moves into a hyperabducted or valgus moment, therefore stretching and causing laxity of this UCL. Patient will complain of pain, weakness, potentially with snapping. Do you hear me snapping? They won't be able to snap because that UCL ligament will allow that thumb to go into more abduction moment. And then they'll have a positive valgus stress test, right? Because there will be laxity. So as we move that joint into a valgus motion, then of course that joint will be very lax if the UCL is actually compromised. So what do we do for it? If instability exists, then we refer to an orthopedic physician to get an x-ray to make sure there wasn't like an avulsion off of either the metacarpal or the actual phalanx itself. So once we rule out an avulsion fracture, then we really honestly just splint it and or tape it. And what we would do, those of you taking the lab, is we'd bring that thumb kind of in towards the fingers and tape that thumb into an adducted position so that that patient doesn't move as much into abduction. The other thing that we can do if it is fractured, what I've tended to see is a hard cast. So they'll do a cast over the thumb and then a cast over the hand and then go up to about mid forearm region to prevent the thumb from going into abduction. So most common in soccer athletes. A swan neck deformity, as you can see here, is kind of the sister to the boutonniere deformity. It is a distal tear of the extensor complex, okay? And so what we can see is we have the extensors kind of coming here on the dorsal surface of the finger, and they'll attach distally. But then there are slips that kind of extend down to what we call as the volar surface or the dorsum surface of the hand. What we tend to see with a swan neck deformity is that there's just this massive tearing or rupture that occurs as a result of hyperflexion of the MCP joint, the metacarpal joint, or what we could say are the knuckles. So you have this hyper extension moment that actually ruptures what we call is the volar plate. And this causes a massive amount of dysfunction in the finger. So signs and symptoms, you're going to have pain, you're going to have swelling over this proximal interphalangeal joint. And the patient, because the volar plate is ruptured, right? This volar plate is ruptured. There's actually no resistance to the amount of extension that can occur because this part is done. So if you guys were to just like sit at your desk right now or sit wherever you're sitting and literally grab your PIP joint and try to extend it, right now what you would get is resistance, right? You can't overextend that unless, of course, you have a lot of laxity. You try to extend that finger and you can't do it. Well, the reason you can't extend that PIP joint beyond its bones is because of this volar plate. When this volar plate gets ruptured, however, what you'll see is you'll be able to extend that PIP joint so much so that, honestly, in some volar plate disruptions, what you'll see is like the patient can almost bend that distal phalanx all the way back to their knuckles. And so this becomes an injury that we absolutely have to treat. And it's usually resolvable by itself. In other words, we're not going to need surgical intervention to repair this if we splint it correctly. So number one, we're always going to rice everything pretty much. Analgesics means pain medication. So Tylenol, ibuprofen. And we want to actually splint, we want to splint the finger in flexion. And the reason for that is when we splint the finger in flexion, it brings the two pieces of the volar plate together and it allows them to heal themselves. So you want to splint the finger in a little bit of flexion to take slack off of the volar plate. And then can athletes participate with this? Absolutely. Just do some buddy taping. Next, we have a metacarpal fracture. So the next pathology that we have are going to be metacarpal fractures. And metacarpal fractures occur to the actual long bone of the hand or long bones of the hand. And usually occurs as a result of either a direct force to the metacarpals themselves or a compressive force. So you put your hand on the ground, and let's take a soccer athlete. Hands on the ground, and then someone steps on that hand with their cleats, right? That would be kind of a compressive force. An axial force would be what really occurs when you're boxing or you're punching something. And so that's an axial force, right? Something that occurs at the metacarpal phalangeal joint, that where the forces are transmitted to the metacarpals themselves. And so you can get a fracture that way as well. So what are the most common signs and symptoms of metacarpal fractures? There's pain, tenderness to palpation along the metacarpal, and swelling. And in some cases, when you're palpating that metacarpal bone, what you'll feel where the fracture is a piano key deformity, right? Where the fracture is, you'll be able to move the two pieces of bone apart or away from one another. You can also do a torque test. So you guys probably recall that I did a torque test with the femur to rule out a stress fracture. You can also do a torque test on the metacarpals, believe it or not. So what do we do for them? Number one, we can rice them. We definitely want to refer out for an x-ray just to make sure that in fact it's a fracture. If it's a fracture, most often physicians will treat it conservatively. What they'll do is they'll actually just splint it. So the splint will be on the palmar surface of the hand. However, we have seen in adolescent kiddos who may not keep their splint on, that the physician will go ahead and cast it. But most often it's a splint for 4 weeks, and then the patient is back to doing what they were doing before they injured the metacarpal. So then next we have Bennett's fracture. And Bennett's fracture is a specific injury that occurs to the actual thumb. More specifically, it occurs to the carpal metacarpal joint of the thumb. And so we think, okay, metacarpal, I get, right? Metacarpal portion of the thumb. And then the carpal bone is actually the trapezium. And so you have the articulation of the trapezium bone and the metacarpal bone of the first ray. And so what we tend to see a lot of times is either an athlete will take a direct blow to the thumb, or they'll land on the thumb very forcefully, the tip or the distal phalanx of the thumb, and the forces will get transmitted and cause a fracturing of that carpal metacarpal junction or joint. And so the thumb becomes so unstable, because we can imagine that if this were a through and through fracture, the thumb would really honestly be separated from the rest of the 4 fingers that we have on our hand. And so this is a truly structurally unstable injury that warrants surgical intervention. So we need to refer. So you'll find out in terms of whether or not they actually have a Bennett's fracture through your palpation, the location of the pain, where they'll complain of pain right at that base of the thumb. So just distal really to the kind of the scaphoid bone itself. They'll also complain with pain with ranges of motion. They'll have lots of swelling distal to that snuff box, the anatomical snuff box. And so it becomes an injury that you actually want to refer. If you are uncertain, if it's presenting like a UCL injury or a gamekeeper's thumb, just refer for an x-ray, because you'd rather be safe than to be sorry with Bennett's fracture. Last but definitely not least, I just wanted to review the special tests that we've covered in the wrists and the hands and the fingers. And the first one is Finkelstein's test. Remember, we did this in class last Thursday, where we had you put your thumbs down into flexion, and then we wrapped those 4 fingers around the thumb, and then we pointed our hands down to the ground. And all of us got a really good stretch of the wrist, as I'm getting one now as I'm doing it. You can't see me, but I am. And that's a test for the De-Quervain vein syndrome, or an inflammatory response of the outcropping of 3, right? That abductor pollicis and those extensor muscles that supply the thumb itself. Tinel's sign and Phelan's test are both tests used to rule out carpal tunnel syndrome. Tinel's test, remember, you turn your hand over into a supinated position, and you're going to tap that distal wrist, and you're looking for numbness and tingling in the carpal tunnel region. And then Phelan's is actually just explained here. Patient puts their hand in an hands, plural, in an upside down position, and they're going to hold that for approximately 1 minute, and we're looking for a neuropathy, numbness and tingling, right? If after a minute they don't have numbness and tingling, then maybe carpal tunnel syndrome isn't your pathology. Last but definitely not least, I mentioned on previous slides that there are definitely ways to test the ligaments in both the wrists, the hands, and the fingers. And so this slide is really dedicated to when we suspect a ligamentous sprain, how do we assess that? And so the way to assess that is through either a valgus or a varus stress test, which you guys are hopefully all familiar with now. Most valgus and varus stress tests are going to occur at the PIP and the DIP joints of the fingers, and then at the interphalangeal joint of the actual thumb. At the wrist, you can do valgus varus glides, but you can also do what we call our dorsal to palmar glides, where you move the wrist from dorsal to palmar, or you could do palmar to dorsal glides to test ligamentous laxity of the dorsal and palmar structures. So these are just different ways to assess different ligaments in the wrist, hand, and thumb. Just wanted to thank you for listening to the online lecture.